that, I will hand it off to Kim Keaton to begin the webinar.
Thank you, Amber. And good morning or good afternoon, depending on where you are. Welcome to CSH's HRSA Bureau of Primary Health Care funded webinar on data sharing between the health and housing sectors. Today we will be discussing how to use and share data to target, refer, and coordinate care for frequent user patients. Today's speakers are as follows. We'll start with me. I'm a senior program manager with CSH, and I sit in our Los Angeles office. Next, we will have Daniel Graber, who's an attorney with Aiken Gump, Strauss, Hauer, and Feld in Washington, D.C. This firm is a pro bono partner of the National Center for Medical Legal Partnership, which is another HRSA-funded TA provider. Daniel will be providing an overview of some of the HIPAA constraints and justifications for sharing data between the health and housing and other sectors and MOU process. Finally, we will have Chris Kuntz, who will be providing us with a community local example of sharing and using data. Chris is a program and research analyst with St. Vincent de Paul Village in San Diego, California. So first, a word about CSH. CSH stands for the Corporation for Supportive Housing. We're a national nonprofit headquartered in New York with offices in 12 states and staff in 18. At CSH, our mission is to advance housing solutions that deliver three powerful outcomes: improve lives for the most vulnerable people, maximize public resources, and strong, healthy communities. CSH works to solve some of the most complex and costly social problems our country faces, like those related to homelessness and frequent use of emergency crisis public systems. So this week I went to the Western Forum for Migrant and Community Health in San Diego. And there, and at nearly every health-focused event these days, the buzz phrase is that housing is one of the so-called social determinants of health. At CSH, we couldn't agree more, and quite frankly, we're wondering what took so long. Taking that idea one step further, at CSH, we believe that supportive housing equals health care for a targeted group of individuals who have complex behavioral and physical health needs and experience homelessness while cycling between multiple systems of care. Supportive housing combines affordable housing with services that help people who face the most complex challenges to live with stability, autonomy, and dignity, like those unstably housed individuals that lack a connection to the preventive care offered by health centers, instead repeatedly using emergency departments and other crisis services. At CSH, we call this group frequent users, but other localities and people call them high-cost utilizers, might be called super utilizers or super users. They all mean the same thing. In today's webinar, what we're going to do is discuss how to use data from both the health and housing sectors in particular to identify, target, refer, and coordinate care for this hard-to-reach and vulnerable group. So as you've seen in your community or elsewhere, and you probably already know, matching data across systems can help understand the community impact of frequent system use. Costs and patterns can be attached to those system interactions and can show that a small subset of folks are costing communities a lot. Graphically, this is shown by matching, at least two data systems against each other. So in this example, we have a homeless system data matched against, for example, hospital system data that contains ER visits and hospital inpatient information. Matching these two systems worth of data on, for example, first name, last name, date of birth, will show a matched subset. Within each of these systems, as the administrators probably know, they have a group of core frequent users or more expensive users who are taking up a lot of the resources. So this is sort of like, folks that are in and out of the emergency room multiple times a year, lots of inpatient stays. On the homeless side, those are usually the chronically homeless folks. Within those two systems, and after looking at the data match, we see a core subset of the most vulnerable of this group. And this is what we mean when we're talking about targeting an intervention at frequent users. So once matched, administrators can know the patterns of use that these frequent users take on in a particular community. Armed with this information, a list of frequent users can be created and used to target and refer specific high-cost individuals for an intervention like care management in a hospital, and for homeless frequent users, supportive housing. Or patterns of use like, for something like 4 ER visits in a year can be used to form screening information for health center or hospital staff for coordinated assessment planning or other service access points for referral to a connection to housing and healthcare at a clinic. Data from a match can also be used to assess how much frequent users are costing a system. That usually makes a pretty powerful argument for an investment in supportive housing, which has been known and shown to often be cheaper and certainly more humane with better outcomes than frequent system use. Cost data can also be used after folks are housed to monitor a program and see how healthcare usage has changed after housing. Often, programs see a drop in emergency care costs and a corresponding rise in the cost of the types of preventive, primary, and behavioral health care that are offered by the health centers that you run. Finally, data from a match on healthcare utilization can help inform care coordination between health centers and housing case management, who use it to decide on care strategies and problem solve for patients/residents. This can include everything from sharing data on the types of care being accessed at a health center, which is harder to share, obviously, to simply appointment information to improve follow-up among patients/residents. We went through this. Okay, so last week, CSH held a webinar on care coordination on Thursday. The speaker, Jeanette Kawachi, discussed a data match that resulted in the Washtenaw County, Michigan Fuse initiative that targets high-cost utilizers of the county healthcare system there and places them into supportive housing. This webinar is still available on our website and will be for a long time if you want to look at it. But I thought I'd start out today with the results of that match since a lot of questions were asked about it. So this match overcame HIPAA concerns by capitalizing on a research initiative already approved by the local hospital and university IRB. This is an example of scanning a community and looking for movement and research on frequent system use within the community that you can use or capitalize on. In this case, the provider agency wanted to know who of the frequent users of the hospital system were also homeless. And so that data came from the HMIS system, which I will go over in a coming slide. Once the match was conducted, they discovered that over 1,500 users of the healthcare systems were also homeless. And they found a strong correlation between the emergency health service utilization, homelessness, serious mental illness, and substance use of this population. So the data really demonstrated overall what has become known as the quote-unquote 550 rule, where a small portion of patients are responsible for 50% or more of a system's cost. What this chart shows is the emergency room and inpatient usage of the top most expensive groups of folks from the match. The repeated use of the emergency care at the county hospitals there has become a self-perpetuating cycle for this group of unhoused patients. The data demonstrates the effect of this system failure for this group, failure for the patients, but also really for the system. So once you have a match, and I realize I'm glossing over some of the legal aspects, but Daniel's going to go over that after me. There are a couple ways to identify folks for a supportive housing intervention. As we discussed previously, the match can generate a group of priority folks who are quote-unquote on the list for the program. Finding them in the community really will depend largely on the size of the community and the number of frequent users that there are, and also on, really critically, on the partnerships and level of collaboration between stakeholders. One example that has worked is to have eligible individuals flagged in a hospital or homeless system database for referral to health centers and housing providers. And Chris Kuntz at the end will discuss how this worked in his community. in a couple communities, number 2 here refers to Los Angeles and soon Santa Clara County in California, the local jurisdiction would only share de-identified matched administrative data. And so the researchers or the community with no way of figuring out who was who looked at the patterns of system use in the data. The group that did this was called the Economic Roundtable, and made a tool that assessed the likelihood a person was a high-cost user. While it takes a little bit of statistical trickery, this is this can be a way to find out who is eligible for kinds of interventions like these, and it can be administered at system entry points of crisis, like at hospitals, homeless shelters, et cetera, again for referral to housing and services. Finally, there are a few assessment tools out there that can be used or adapted to be used to assess frequent system use. One of these, the DESC Vulnerability Assessment Tool, is used in the Bud Clark Commons project in Portland. CSH featured this program on our January 14th Health and Housing Partnerships webinar, which is also still available on our website. So, taking a step back, as you probably know, there are a lot of players in local systems of care for vulnerable folks that we all try to help. Each of these can potentially be a partner in a supportive housing and healthcare initiative. And the reason why is that frequent users really touch all of these systems. They're in homeless shelters, they're trying to get money from local welfare agencies. They are bouncing between a clinic here and there. They're going to emergency departments on their own. They're calling 911 a lot, or the police are calling 911 for them if they're on the street. They may be in and out of the jail and involved with the court system, and they may be involved with a local social services agency or mental health or behavioral health services agency as well. Because many of this kind of data, the data that comes from these, especially the health-related players, are covered by HIPAA. Daniel's going to be speaking after me and providing an overview of HIPAA concerns for that. So I'm going to finish with a short overview of the homeless system data quickly before turning the presentation over to him. Our webinars for health centers are usually targeted at health centers, which may not be fully aware of what homeless system data is and how it's organized and contained, what it contains. So it's a system that contains most community, or should contain most community housing and homeless data. HMIS stands for Homeless Management Information System, and according to HUD, it is a local information technology system used to collect client-level data and data on the provision of housing and services to homeless individuals and families and persons at risk of homelessness. Each continuum of care, which is a coalition of regional service providers that together receive funding for the provision of homeless services, is responsible for selecting an HMIS software solution that complies with HUD's data collection, management, and reporting standards. So essentially, this is how HUD, the federal government, keeps tabs on the amount of homeless folks in the country and what kind of services they're receiving. A local area's homeless information system will contain usually ideally everything from outreach information on the street to shelters, to rapid rehousing, to housing and services. HMIS, it's important to note that it does not come under HIPAA since it's not health information, but it is still protected to a large extent, just not quite as stringent. Major considerations when a healthcare entity is interested in attempting to share housing information that is covered under HMIS data is to note that many agencies report into a local HMIS system, not necessarily just one agency. So depending on if you want to share, you want to know general community homeless information, or you're just looking to share data with one service provider, that's something to keep in mind. And then if you are looking to look at, general community homeless information, you should note that there's typically a general consent that's signed when people first enter the system. It may or may not have the protection written into it that you need, and it might need to be looked at and possibly amended for the purposes of the project. I don't want to go too far down that road, but just to note that it's something that happens and something to ask about. With that, I am going to turn the presentation over to Daniel Graver. Let me just pass the presentation to him, and then we'll be ready to go.
Great. Thank you so much, Kim. My name is Daniel Graver. I'm an attorney with Aiken Gump's Privacy, Data Protection, and Cybersecurity practice, and our firm has served as pro bono counsel to the National Center for Medical Legal Partnership since 2011. So, as Kim discussed, there are a number of different privacy laws that have different levels of protection for different data. I'm going to focus most of this presentation on the most restrictive, which is HIPAA, but your partner organizations may have to comply with other laws, from Gramm-Leach-Bliley to the Federal Trade Commission's Health Breach Notification Rule, which mostly applies to personal health record vendors, Part 2, which is federal protection for certain substance abuse treatment records, and everyone should definitely be thinking about state laws. State laws, if they're more stringent than HIPAA, then they are not preempted by HIPAA, and you have to comply with them. For example, if you're in California and you're trying to get an authorization form to share protected health information, it has to be in 14-point font. Those are the kinds of things that it's worth looking at state law for. So HIPAA, the core concerns of HIPAA protects protected health information, which is individually identifiable information created or received by a health plan or certain healthcare providers and relates to the physical and mental health of an individual, including their demographic information. HIPAA protects PHI held by covered entities, and covered entities are health plans, certain healthcare providers, and healthcare clearinghouses. The core tenets of HIPAA, there are basically three parts to HIPAA. The first is what's called the privacy rule, and generally what the privacy rule says is that protected health information of individuals must be kept confidential. The security rule says that you must, like anyone who's holding PHI, covered entities must have reasonable and appropriate physical, technical, and administrative safeguards. For example, if you have PHI on a computer system, a technical safeguard is requiring someone to have a password before they can log in. HIPAA also has a breach notification provision, so if the confidentiality of PHI is compromised, the individual has to be notified, and in some cases, the Secretary of Health and Human Services also would have to be notified. Now, if you want to share PHI, as a general rule, you can't share it unless you either have an authorization or other appropriate justification. So this list broadly walks through how you can share PHI using a number of different tools. For example, you can share PHI with a written authorization. Basically, you could, if you have an appropriate written authorization, you can share PHI for any purpose. You could, if you had an authorization from me, you could put my PHI on a billboard. The next level down, there are, however, you don't have an authorization to share data from that individual, you can share their PHI without an authorization for certain treatment, payment, or healthcare operations purposes. We'll get into those a little bit later, but those are more restrictive. For example, there are minimum necessary requirements that apply. You can only share the amount of PHI that is sort of like reasonably needed for what you're trying to accomplish. And it's also limited because you can only share PHI for treatment or payment or healthcare operations. So an example of that would be a hospital can send PHI to a payer for reimbursement. The next level down is you can also share PHI with basically a vendor under a business associate agreement. This is more restrictive because the business associate, even though it doesn't require an authorization to get that data, the business associate can only use that data for the purposes of providing services to the covered entity that shared the PHI with it. It would have to sign a business associate agreement, has to comply directly or contractually with much of HIPAA, and the business associate cannot keep the PHI and cannot use it for its own purposes. An example of that is if you hired an electronic medical records vendor, your patient's PHI would get sent to that vendor, but the vendor isn't allowed to keep that data once the contract is up and can't use it for its own purposes. Like, it can't use that PHI to market based on that authorization, or without an authorization. When you're thinking about data sharing, and this applies to any privacy regime, data can only be sent to another entity with an appropriate justification. So if you're a health center and you want to share PHI with a partner organization, you need to have a justification. So if you have a signed authorization, no problem, you're allowed to send it with basically no restrictions. But if you don't have a signed authorization, there are a number of other tools that allow you to move that data. For example, treatment, payment, healthcare operations. If they're a business associate, you can share. Also, this is other choices are, for example, de-identification, which is something that Kim touched on, which is if you remove all of the identifiable characteristics and there's a specific subset of what has to be removed, that's no longer protected health information and can be shared for any purpose. There's also the opportunity to share a limited data set, which is mostly de-identified, but allows you to keep some data elements like dates in it, and that could be shared under a data use agreement with a partner organization. Let's talk about authorizations for a minute. So written authorization is the safest option to share data under HIPAA. Authorization forms, you need to check the local laws, like I mentioned, but under an authorization form, you can do pretty much anything with the data. But you need to watch out for specific types of information. If you're trying to share mental health records, if you're trying to share drug and alcohol treatment records, or HIV/AIDS test records, those are types of information that frequently have additional requirements or special authorization form requirements as you're moving through and trying to share those records. But if you don't have an authorization form, if you're just trying to figure out how to do your original match, data match, there are other choices. So this is a very fact-specific inquiry, and I just flagged that, like, based on your particular facts and circumstances, which is something that you should be talking to your privacy officer about when you're trying to figure out how to share data. Like, there are ways to share data, but it's very fact-specific. Healthcare operations is one of the exceptions in HIPAA. To the extent that the activities are related to the functions that make a covered entity a healthcare provider, they can share protected health information for example, population-based activities related to improving the health or reducing healthcare costs, or case management and care coordination purposes. For example, that's basically sort of like for the general administration and business functions that allow hospitals to function. For example, cost analysis is one of the things that will allow you to share that information. Another one of the HIPAA exceptions is for treatment. So you can share PHI for the coordination or management of healthcare by a healthcare provider with a third party. Again, it's fact-specific what exactly counts as treatment. But the prototypical case here is, for example, one physician could share a patient's PHI with a specialist, like a healthcare specialist, if they were referred for healthcare problems. The other option that I'd mentioned is a business associate agreement. business associates, as we've discussed, they receive PHI without a written authorization, but they're limited. They can only use that data for those specific limited purposes of fulfilling a function for or on behalf of the healthcare provider. So it is limited, but basically if you're looking for a way to justify this, overall, no HIPAA problem can't be solved with the right piece of paper. So when you're thinking about data sharing, there's usually a way to get there. We're going to shift gears a little bit and talk about a memorandum of understanding. Now this is different than the other slides. This is not a HIPAA justification, but it lays out your justifications for data sharing through a partnership. So if you're looking to set up a partnership to share data and do a data match between housing providers and healthcare providers, a good place to start is a memorandum of understanding. Now, the MOU forms the foundation of your partnership, and you can base other contracts on it later, but basically it's an agreement that formalizes and supports the partnership by laying out key responsibilities and expectations of the different partners. Then this is an opportunity to sort of like set up your joint priorities and identify what you're trying to accomplish. Just because it's important to note, again, like just because you both agree that PHI can flow doesn't necessarily mean that it can. You must make sure that you have an appropriate justification, but this is the kind of document that the partners can use to lay out precisely what their justifications are for sharing data and what they want to accomplish with that. Now, as a tool for putting together an MOU, the National Center for Medical Legal Partnerships has created something they called their Phase 2 MOU MLP Toolkit. Now, this is the checklist from the National Center for Medical Legal Partnerships, and but it's a tool, and even though this is generally for a partnership between a medical provider and a legal provider, it has many of the same issues that you would need to address in a partnership between a medical provider and a housing provider. And 70 to 80% of what is in this MOU, all of the care terms are certainly applicable, plus it has useful examples, and this is freely available as a tool to you. And I'll have details at the end of my section on how you can get not only the checklist, but the full toolkit that walks you through the MOU process. Now, every MOU would have a preamble, sort of like a statement of the purpose, setting the partner's strategic goals, and would also cover things like training and evaluation. How are you going to measure whether or not your partnership is being successful? Also cover funding. How are you going to pay for the data match? Who's going to be, and that's in staff time or in financial resources. Administration, who's responsible for which pieces, term, renewal, and termination. It's also a place where, as we mentioned, is a good place to talk about privacy. So the goal of this partnership is to share information, and specifically what goes into the privacy and data protection section will depend on who the different partners are, what kind of data they're holding, and what kind of protections apply to that data. But this is an opportunity to lay out amongst the partnership the fact that different partners have to respect and honor the patient information and medical records that they access while participating in the partnership. It can outline the partner's responsibilities towards patient privacy, and importantly, it allows partners with different privacy or data security obligations to assure that they understand and will respect the privacy and security obligations of their other partners. All right. Here's one example of a way that this data sharing might work. So as we've discussed, there are many potential ways to share data, and it all depends on your partnership's specific facts and circumstances. But here's one way that this could work out. So here, health and housing and potentially other partners could enter into an MOU laying out their goals for the partnership and their data sharing privacy and security responsibilities. Then the healthcare provider could go through its own records, as Kim mentioned, and identify its super users. Now, potentially the healthcare provider could partner with other healthcare organizations, like other hospitals in the area, to identify a list of super users, because you might have individuals going to 2 or 3 different hospitals who's still a super user in the community. And once they've sort of identified those individuals, that's, I think, and this again will depend on your partnership, but seems to be a good opportunity at that point to get a written authorization, which is a clean, clear way to share those individuals' data with the housing providers. By definition, a super user of healthcare will soon go back to a healthcare provider. So if they're flagged in the healthcare provider's records, that's an opportunity when they come in again for the healthcare partner to get a signed authorization in order to share that individual's information with the housing partners to allow the data to be matched back, identify the chronically homeless, and then refer them to services. And again, like I said, this is one example of one way that you could get to a signed authorization to share data, but there are many other opportunities. This slide is just an overview on data sharing generally, and is in here to assist in thinking through the kinds of issues you'll need to address when setting up a data sharing agreement. So, for example, when you're looking at how to share data, you need to think about where's the data housed, who needs access, how is it transmitted. Sort of you can think through the minimum necessary amount of information that you need. If you only need like the person's name and the fact that they're a super user, then there's no reason to be sharing more of their particular medical profile. This slide is here as a resource to think through how to have these discussions with your privacy officer when setting up your specific data sharing agreements. And so that's sort of why it's here as a resource. And these are the kinds of things that your privacy officer has to think through in terms of your data security and privacy within your organization. Now, finally, this last slide contains the information you need in order to request a free copy of the National Center for Medical Legal Partnerships MOU Toolkit. This is, it's a free tool that they ask you to request it from them instead of just having it on their website, only because they just released it and they'd like to get a sense of who's using it. But having gone through it, I think that it lays out, based on their experience over many years, sort of best practices for setting up partnerships and MOUs and sort of the process to go through to get that accomplished. And with that, I'm going to hand the presentation over to Chris, who will explain how his team put all of this into practice.
All right, hello everyone. This is Chris Kuntz. I work at St. Vincent de Paul Village here in San Diego, California. I am the program and research analyst. Basically what it means is that I help with evaluation and data analysis for the agency here. So before I jump into some of the things that we've done here regarding data sharing for frequent users, I want to do a brief little overview of our agency. We have a lot of different programs, a lot of different housing programs, in addition to our federally qualified health center. So at Father Joe's Village, we have affordable housing, we have permanent supportive housing, we have transitional housing, rapid rehousing, emergency shelter, and then our health center. In addition to all these housing programs and our health center, We also have a state-certified outpatient drug program. We offer mental health counseling. We have a therapeutic child care center, which is a state-licensed child care facility in addition to providing integrated behavioral health services to kids 0 to 5. And then also we are the SOAR lead for San Diego, along with CSH here, and which is a program designed to help homeless or those at risk with a disabling health condition access disability benefits really quickly. So a little brief overview of our FQHC. We are actually, the picture you're seeing there, we are co-located on site at our emergency shelter here in San Diego. So we are that bottom right-hand, the first floor. We primarily focus on the homeless population, but we do provide services and care to those who are living in some of our affordable units within the agency. One thing is really unique about our clinic is that we have a residency program through UCSD. It's a dual residency program where doctors are trained both in psychiatry and family medicine at the same time. So for the homeless population, you can imagine that a lot of those folks are struggling with mental health issues along with physical health issues. So the idea that they can see one doctor to really take care of both is a huge advantage for us. We do also have limited dental services on site. So I always talk about, in the first slide you saw that our FQHC was just one of our programs, but I really like to think about our FQHC as sort of the hub within our housing programs, that we've really made our clinic an integral part of the housing and wraparound social services for all components of our housing, from affordable housing all the way through to, an emergency shelter. So I'll talk a little bit more about that here in a second. So now getting to data. So I'm going to talk about 3 different ways that we use data within our agency. I'm going to talk mostly from our clinic's perspective, but again, we do also kind of be sharing some housing and social service perspective as well. So one way we do it is through targeting and referral. So we use data to target and referral. We're working really closely with our local 911 system, and I'll talk more about that in a second. We have received data from hospitals as well as law enforcement for targeting and referral. For coordinating care, I'll explain a little bit how we're using some of our local data exchanges. One of them is the Community Information Exchange, and one of them is our local HIE Health Information Exchange. And we're also now really working closely more with the managed Medi-Cal health plans here in town. And as well as we provide coordinate care between housing and social services. And the last thing I want to touch on during today is how we use data to measure our outcomes. And Kim mentioned this a little earlier in the presentation, but using data to measure programs, doing a cost-benefit analysis, also looking at utilization rates, maybe of the 911 system, of ERs, of law enforcement. All right, maybe some of you guys have heard about Project 25, but I'll give you a really quick overview. So Project 25, it started a few years back, 2011. It was a 3-year pilot funded by the United Way here in San Diego. Our agency was the lead agency. What we did with several other entities throughout the county is that we established a frequent user list, and I'm going to touch on that here in a second. We did identify 36 chronically homeless frequent users. That it was a housing first model, which meant that it was a case management program that actually literally took people from the streets who were frequent users and homeless and took them into their own apartment. And then we provided the wraparound social services and all the health care services were delivered through our FQHC. We used a health home model, which is, again, the combination of housing and social services and health care. Harm reduction model, which meant that this program was not an abstinence model. We weren't requiring people to get clean and sober. We were really focusing on how to reduce their harm if they weren't willing to stop drinking or using drugs. And a strong emphasis was on data collection. Because the United Way really wanted to prove to locally here that it costs more to do nothing. I mean, there's been plenty of studies across the country that have shown the benefits of providing housing and support to frequent users who are homeless, and so this was really San Diego's way to do this. So how did we create an initial list? So what we did is we worked with 2 local hospitals. We worked with the jail system and the city's 911 system, and then we worked with our county behavioral health services. So the United Way was really responsible for creating the initial list. So they created the MOU to share data, and it was really, the goal was targeting and referral for treatment. The idea was that these entities were going to share information. Very minimal information was used, but for targeting for treatment. Minimal data was basically just their name and the utilization data. And the utilization data was even summarized. So, for example, data would include that the person, went to the ER so many times, but it would not say, why that person went to the ER. There was no medical, health information involved. So the county and us were kind of helped organize that data. And then once we had the list and we started finding people off this list, we actually then had participants sign an authorization, and we started collecting data from other multiple partners throughout the county. So I think we ended up with about 22 hospitals that ultimately shared data for the course of the 3-year pilot project using that signed consent. So fast forward to this year, so the United Way money ran out, but I'll show some of the outcomes to the project here at the end. But it was a huge success. Like other models across the country, we did prove that doing this model saves money, decreases utilization of hospitals and jails. So what we did is we started trying to expand the model, and we started working with our local managed Medi-Cal health plans. And so to get our next list of new people into the program, we had 2 different ways that the health plans could refer people into this program, and then would pay us to provide housing and social services and healthcare to these folks. So option 1 was that we have, St. Vincent's, we have agreements with our 911 system, that the 911 system provides referrals to Project 25. So what we did is we got some names of people, high users of the ambulance system that were on certain health plans, and we would then shared those names with that health plan to identify people who were frequent users. And then option 2 was that we said, to the health plans, if you can look into your own systems and identify which ones are frequent users to refer to this program. And then we did have some, so part of this, we do have a SAMHSA grant right now with Project 25. So SAMHSA would, require that the person was chronically homeless, obviously, that the person had some type of substance abuse or mental health condition. And then we also put some restrictions on we want to make sure that we were targeting frequent users as well as people who are high-cost frequent users. All right, another way that we target people using data is our community information exchange. On the left-hand side, this is where the community information exchange would like to go in the future. At this time, it is really only St. Vincent's, the 911 services here, and another shelter, another local shelter are sharing data in the exchange, but hopefully it's going to be expanding to more folks, more entities. To have individuals share their information, they actually sign a consent form that allows that they're giving consent to share their information into this exchange. And once a consent is received, data is matched between our HMIS system and the 911 system and then the other shelter's data system. So we share information from all these places on common patients. We are in discussion, so right now we're just sharing pretty limited, HMIS universal data elements, which are pretty straightforward stuff into the exchange. But we're looking at sharing a little bit more information, but we might have to do some adjusting with the consent. So we're actually looking at how can our actual health center start sharing data into the exchange. Here's just a really quick screenshot of, if you log in, you can see the ambulance transfers for this is actually one of our Project 25 folks. You can see they've been writing, pretty actively still. Coordinating care internally. So going now to how we actually use data to coordinate care. Like I said earlier, our clinic is an integral part of our housing and social services here. We have a notice of privacy practice that we allow for disclosure of health information for treatment purposes within our agency. Our clinic is part of multidisciplinary teams. Also, some of our social service staff, housing staff, have really limited access to our clinic's database. So, for example, our staff can go in there and schedule an appointment, and things like that, but pretty limited stuff. Also, our clinic staff has access to our HMIS system, so they're able to go in there too and see where are they living, who's their case manager, and things like that. Lastly, we've been creating some reports that our clinic staff can use that pulls data out of our HMIS system and pulls data from our community information exchange. So here's an example I'll show you guys about the high utilized report that we have. So this is a report that our clinic staff and any of our social services staff can run. It provides data for people who are currently living in any of our housing buildings. It looks at their 911 data, looks at their VI SPDAT scores, age, their health insurance, who their case manager was or is right now, and then also what's their utilization at our clinic. When was the last time they saw someone? So this can help, if we have these frequent users that are not getting access in our clinic, we need to get them into it. So using data exchanges, like I mentioned, the CIE, we can use CIE to target people, for services, but also it's a way to start to coordinate care. So staff can send secure messages to housing staff who are outside the agency as well as inside the agency. And the CIE system is working on receiving alerts if someone rides the ambulance. So if you're part of that person's care plan and they go to the ER, you might be able to get an alert very soon in the CIE system. Our clinic also participates in our HIE, and so our clinic does receive alerts from hospitals if patients are admitted. And so we do share those, if someone is admitted to a hospital, that might be shared within their care team in our clinic, which would include, case management staff as well. And so here's some of the things that are in the works for care coordination. We're trying to work with our community paramedics. So our local community paramedics have a model now where they can actually, if someone calls the ambulance, they can show up on the scene and actually divert them from the ER to maybe like a clinic. And so we're going to be talking with them more about how we can take some of our people that we're caring for and divert them back to our clinic for situations that really make sense. We're also really kind of building partnerships with health plans, so we're trying to work with them on getting some reports that on patients who are assigned to our clinic. That it might be a monthly report that looks at folks who have had an ER visit in the last 30 days, maybe who had an inpatient admission, skilled nursing, things like that, that we could then really use to coordinate their care within our clinic. So the last thing I want to touch on today is using data to measure effectiveness. And so let's talk about the cost benefits for Project 25. So the final report has not been fully published, so this is kind of a sneak peek of what will be in the published report that will hopefully be out here in probably a few weeks. And so we've used data to show that over the course of its, a couple years we've been doing Project 25, that we've seen huge decreases in all, from jail use, hospitals, ERs, we've seen huge decreases in cost and service utilization. Money has gone, from 28 people cost $3.5 million in 2010 while they were homeless on the streets, and to fast forward to 2013, we saw these folks are still costing a lot of money. They are still, would be considered frequent users, but they are definitely, they've cut that cost, more than half. Average person in our program, Project 25, cost about $124,000 in 2010 while they were homeless. Fast forward to 2013, they were still, costing the system money, just, not as much. And here's a slide that shows the decreases in service utilization. So you can look at, homeless is the dark blue, and then Project 25 year 1, the light blue, and then year 2 is the lighter blue. So when we talk about frequent users, Project 25 folks were on the far end of the spectrum. That, if you look at the ER visits, that 28 people is over 1,400 emergency room visits in a single year. That's a lot. We also use data in our clinic, utilization of our clinic services. So what you're seeing here is a slide that shows on a quarterly basis, the average person, how many visits in our clinic they had in a quarter. So, in early 2012, you saw that roughly, each person was going to the clinic a little over once a month. So there's a lot of utilization in our clinic in the beginning as we were really trying to stabilize their health conditions. And then, over the course of 2 years, it really got down to, less than once a month. However, still, if you look at the last quarter of 2013, 2.5 visits in a quarter is still probably a lot more than, maybe an average patient would have. All right, last thing, we got a few seconds here, but we are looking at, these are the top 30 hotspots of 911 use in the city of San Diego. Project 25 has done a really good job of decreasing frequent use, but then we found out recently that our agency was the #4 hotspot in the city of San Diego, only behind the border, the airport, and the freeways. So this was kind of shocking news to us, and we said, wow, we got to do something about this. So we're trying to really decrease 911 calls agency-wide. We're part of a Institute for Healthcare Improvement collaborative, and our goal is to see if we can get us, from #4, hopefully farther down that list. But we're digging deeper into our data to determine, what calls are appropriate versus inappropriate. Obviously, we have a lot of people on site and a clinic, so the fact that we're, having a lot of calls could be very appropriate. But our clinic is also doing, a good job of training other agency staff, such as our security guards, shelter staff, about alternatives to 911 use. And we're trying to educate clients, too, about alternatives, maybe using their health insurance to go to an urgent care. And so we're going to be measuring 911 data across our agency for the next couple of years and see kind of where we fall. Lastly, lessons learned, recommendations. Accessing data from various sources, it can be time-consuming and it's difficult, but sort of like what Daniel said earlier, it's doable. What I've found is that establishing good relationships with entities to share data is really the first step and essential. If you don't have that relationship with a provider to do it, it probably won't happen. Then as you build that relationship, then starting to work on MOUs, business associates agreements, consents, to me, that's like the next step. Also, some entities will have better data systems than others, so really trying to understand their data systems capability is helpful for when asking for data. And also find entities where sharing data benefits both parties. Our 911 system has been very open to sharing data with us because they know that if we do this stuff, it can really help to address some of their most difficult patients. And with that, got a few minutes, so I'll hand it over to Kim.
Thank you, Chris. We ran just a couple minutes over, but not too bad. Now we are entering into the question and next steps portion of the webinar. Jane Bilger from CSH will be managing the questions. And just a note that we will do what we can to answer questions today. We might go a few minutes over. If we can stay on, that's great. And then afterwards, we will be transcribing all the questions and providing answers to all the questions. If we don't get to it today, we will get to it. So why don't you go ahead, Jane?
Sure. We did have a number of questions as we expected. So first off, Daniel, when you were doing your presentation, there were a couple of questions about data sharing for research purposes, and what type of authority does the authorization from a hospital affect the ability of organizations to send and receive identifiable data? And there was also a question related to a phrase, data collection preparatory for research, a clause that's in the privacy rule. Can you address any of those questions as it relates to data and for research purposes?
Sure. I mean, in terms of research, there are specific and pretty stringent rules that apply to research, and there are, if you looked at like sort of a lot of the data sharing that you could do without an authorization, for example, under healthcare operations, you can share, you can use PHI without an authorization in some cases, but it explicitly can't be for like research as defined as sort of like the obtaining of generalizable knowledge. So I mean, for research, I would stick with you need to get patient authorization in order to do research for anything you'd be publishing. Hope that addresses the question.
Okay, and we can do some follow-up on that. There were a couple of questions that came from the perspective of the Homeless Management Information Service system lead, so the HMIS system, and they were wondering if do we need two MOUs between the HMIS system, one with the healthcare agency and then one with the housing providers. So are there, is an HMIS system going to have multiple MOUs depending on who they're partnering with?
This is Kim. I'm going to go ahead and answer that, and I'll make sure and follow up to make sure what I'm saying is true. But in my personal experience, there's an MOU that governs, MOU or some other kind of agreement that governs the information that's shared between an agency that, either reports data directly into an HMIS system, or if they have a different sort of, a different case management provider uploads files to an HMIS. So that's one. But if the HMIS entity that manages all the data from a continuum of care is looking to share data with an external provider that does not report in, then yes, that would be separate MOUs.
Okay. There was also an IT question about do all providers need to encrypt emails that have personal health information, or is there another way to share the PHI data that complies with HIPAA and other privacy rules once you're under an authorization or once you're under a business associate agreement? Anybody want to take a stab at that?
Sure. This is Daniel. So encryption is addressable, not generally, but more and more is moving towards required. But there's a lot of ways to share PHI. It doesn't have to be in an email. A lot of times you can move PHI, like move encrypted files off of like an encrypted FTP server. There's other ways to do it. I would certainly caution against any system where you are simply emailing unencrypted PHI out anywhere, because I will say a large part of my practice is privacy breaches, and overwhelmingly it's someone typed in the wrong name into an email address and sent a file somewhere it shouldn't, and you don't want to have to be talking to the Secretary of Health and Human Services about that breach. So I would recommend encryption certainly, although there are other technical ways to get around it.
A quick question for you, Chris. Somebody asked if you can talk a little, well, they're looking for more information about setting up a community information exchange. Where can they get some information on that, and how that fits in with the type of work that you're doing? So if you can just talk a little bit more about how you set that up, and I think we'll certainly follow up potentially in other webinars about digging in a little bit further on setting up these arrangements.
Yeah, so our local CIE, there is a website. I think it's either CIESanDiego.com. So it's just Google CIE San Diego, and there'll be a lot of information on it. As far as setting it up, CIE has been in the discussion for several years. So it was not an easy thing to do. I mean, a lot of lawyers around the table, and then also a lot of IT staff to actually, to get to the technical side of sharing data. And so I think it's well worth it, but it definitely took a lot of work to get to where we are today. Even with just having 3 providers sharing data, it took a lot of work.
Okay, there were a couple of other questions, but we're going to try to answer those in the written FAQs. Thank you all for participating. And Kim, you want to close us out?
Sure. I just wanted to let folks on the phone, on the webinar, still know that here's 4 of our upcoming webinar events. Next month, exactly 4 weeks from today, we'll be hosting one on housing and services resources for serving frequent user populations. This will be both typical housing service resources and also atypical ones and unique ones that communities are really braiding funding together that is unique and interesting and things to consider for your own community. And then we have a few others that are later on. You can find out more about these by visiting us on the web, csh.org/HRSA-TA. And then finally, here's some further resources that you'll be able to click through to these when we send you our slides. And there's our HRSA-TA page. There's a Center for Medical Legal Partnerships page, including an issue brief they just recently put out about HRSA-TA for house centers. And then also the CSH partners with the National Healthcare for the Homeless Council and on our TA, and they have their own technical assistance website, so that's here too. And finally, I just wanted to make sure everybody knows what CSH is, a national cooperative agreement with HRSA, and which means we receive funds to help health centers and lookalikes meet program requirements and improve performance. This supports health center program development and conducts national analyses and TA around some of the really vulnerable populations in America, like those who frequently and inappropriately utilize health system resources, and underserved communities and populations like homeless, public housing residents, migratory and farm workers. Thank you for joining us today. We really appreciate it. And a special thanks to our presenters, Daniel and Chris, for putting together the really, really rich sets of slides and presentations on sharing data, both from a legal perspective and then sort of from on the ground perspective. I think lots to learn, much more to talk about, and I really thank you for making time for this today. So with that, we will end the webinar, and please keep a lookout in your email for the recording and follow-up information. Thank you.